Good afternoon. Good morning to all of you. We will be reporting about radiotherapy. Okay. Radiotherapy is given with intent to cure as part of a radiation surgery treatment or for palliation. The dose is high, but the course of radiation is prolonged, and early and late effects are common. In palliative care, radiation provides relief of bleeding, pain, ulcerations, and oropharyngeal obstructions. Principles of radiotherapy. The role of radiotherapy was discovered in the 19th century, and radiotherapy uses either high electromagnetic energy or high particulate matter to destroy malignant cells. Ionizing radiation causes cell death by disrupting the DNA configurations and function. Radiotherapy is indicated for the treatment of early well-vascularized lesions and for treatment of small foci of malignant cells adjacent to a large lesion, and it is also used in the treatment of early metastasis to cervical lymph nodes.
Here are the advantages and disadvantages of radiation. First, the advantages of radiation. Major surgical procedures avoided. Early metastatic cervical lymph nodes can be treated. There is no cosmetic or functional defect, and malignant lesions from other anatomical sites can be treated at the same time. The disadvantages are risk of post-irradiation osteoarterial necrosis, harmful effects on some tissues due to overdose. The treatment with radiation is not very successful in case of recurrence or failure. The tip which came in the line of radiation. Teeth which came in the line of radiation may have to be extracted prior to radiotherapy to avoid the risk of traumatic dental extractions at a later date, which can lead to osteoarteritis. Radiation of the salivary glands can cause dryness of the mouth. Also, radiation therapy can induce cataract formation and other complications such as loss of hair, fibrosis of muscles, and dental caries. Indications for radiotherapy. These are the early vascularized lesions, elective irradiation of the salivary glands to destroy malignant cells peripheral to a large lesion after surgical procedures, palliative radiotherapy for large lesion which is not surgically amenable. Patients who are considered to be anesthetic or surgical risk, patients having period surgery, and long previous irritation.
Next are the methods of radiotherapy. As listed on the slide, there are 6. I will discuss it one by one. First is the external beam therapy or teletherapy. As the word implies, external, so the source of radiation is placed external to the body. And gamma rays used in this technique is derived from radioactive materials such as cobalt. This technique is given by fractions to obtain the maximum destruction of the tumor with minimal destruction to the normal tissues. Next is the intraoral therapy, so intraoral. spares normal adjacent tissues. Next is the electron beam therapy. Electron beam therapy. Electron beam therapy, it is like the intraoral cone therapy, but it uses a bigger portal. And electrons wave photons are used in this technique. Next is the interstitial therapy. Interstitial therapy. This is indicated for the treatment of the small volume of malignancies, such as in the treatment of skin lid lesions, salivary glands, buccal mucosa, soft palate, posterior pharyngeal wall, and it is given in a short duration. Next is the radiotherapy or intracavitary radiation therapy. This therapy, it uses radiation implants, where these implants are contained in a protective container, and it is directly applied to the tumor. This technique, it can also be placed within the tumor or in the tissues adjacent to the large lesions. And it is usually combined with external beam therapy. And lastly, the radioisotopes. This treatment involves radioisotopes, and the therapeutic effects are obtained when the organ concentrates or increases the dose. The radioisotopes can be placed in body cavitation by chelating or combining them into a high molecular colloid. And these colloids that are in the cavity delivers high surface dose with little penetration. Radiation sources. For the treatment of superficial tumors, radiation with low penetration are used. Low kilovolt radiation, 50 to 300 kilovolts, they are used in treatment of skin and lid lesions. Electron beam therapy, which provides superficial radiation, largely replaced the low kilovolt X-ray machines because it provides rapid build-up of dose and rapid follow-up. Electrons may be used in providing radiation to skin lesions, parotid tumors, and cervical nodes. Megavoltage radiation of cobalt, or linear accelerator of 4 megavolts is said to be bone or skin sparing because this radiation is placed within the skin. And the linear accelerator provides variability of elevation due to the ability of the accelerator to vary photons.
Next is the complications on the radiotherapy. One is osteoradionecrosis. When you say osteoradionecrosis, these are changes in the jawbone resulting from, after irradiation, resulting from damage to the bone and as well as impaired vascularity. Then the gross necrotic lesion begins at the interdental papilla of the mandibular molar because it was the center of radiation. The lesion then extends to the cervical gingiva, to the attached gingiva, up to the cheek mucosa. The patient may experience thermal sensitivity of the tooth, and as well as impaired continuous tooth pain. The pain in the jaw may be continuous and severe. Then other complications is radiation myositis. When we say radiation myositis, it is the inflammation of the oral mucous membrane after irradiation. Because the basal layer of the oral mucous membrane contains differentiating intermitotic cells which are sensitive to radiation. It develops mostly on the second week of radiation therapy. Then the oral mucous membrane has an area of redness and inflammation, and it becomes atrophic and thin. The management of this disease is application of topical anesthetizing agent for relief of pain. Then the most commonly used is nitrogen hydrochloride. Okay, last is how can we manage when we undergo radiotherapy. Before undergoing radiotherapy, the patient should be made dentally fit to avoid the risk of traumatic extractions later. Then it's a great importance that the patient scheduled for radiotherapy must undergo thorough oral, clinical, and radiographic examination to minimize the radiation needs post-radiotherapy. And the decision to remove the teeth is its inability to restore or on its poor prognosis. Then, if the tooth does require removal, preoperative chlorhexidine rinse and prophylactic antibiotic must be used. Thank you. Any questions? Last question. Questions? Yeah.
After radiotherapy, how soon can we perform extraction?
Again.
Understanding.
Please use the mic. Please use the mic.
How soon can we perform an extraction after radiotherapy?
Okay. He's asking that when can we extract after radiotherapy?
Okay. Before radiotherapy, if the tooth is affected under radiation, we will extract it 2 to 3 weeks before radiotherapy. Then, after radiotherapy naman, we can extract it right after radiotherapy, but there's no signs. But
we need to clarify that there is complete termination of myositis.
Yeah.
Other questions?
Virginia.
What if the patient has braces? Can the patient undergo radiotherapy?
What if the patient has braces? Can the patient undergo radiotherapy?
If the patient has braces, we should remove the braces first because it will affect the bone
Where there is presence of osteoid necrosis.
Yes.
And the brackets or the treatment should be, it can be placed, it can be continued after the patient is free of cancer for 1 year. Next,
Well, Mr. Rubio has mentioned providing a dental treatment, but he or she is undergoing radiotherapy. Can she receive treatment? Why or why?
Can the patient receive dental treatment under radiotherapy? No.
When undergoing radiotherapy, there is no dental treatment need. Because if we do dental treatment, there is a wound left.
For example, we've done extraction of a patient under radiotherapy, and the wound is open. So we all know that radiation will affect the wound. And the bone is exposed, so there will be a higher risk of
Osteoradionecrosis. Miss Velasquez.
What if the patient is denture wearer? Does she need to wear Does she need to wear the denture, or it should be removed? Why?
She asked that if the patient is denture wearer, should it be removed or should she wear it? Why?
The patient should remove the denture because it will, when doing therapy while having denture, it will irritate it can irritate more the tissues, the oral membrane. So it has a higher risk for mucositis. The last.
You mentioned earlier about the osteoradionecrosis. What is the treatment for that?
Treatment for osteoradionecrosis.
The treatment for osteoradionecrosis that I researched before is hyperbaric oxygen.
Because with hyperbaric oxygen, simply saying words, it is pressurized oxygen. The patient is placed in a pressure chamber like a cell, like this. The patient is placed inside, and the oxygen is circulating inside. Where the oxygen saturates the bone.